All set, Mary.
Okay, good. Well, welcome everybody to our second Zoom board meeting. Thanks for attending. I need to make an announcement before we start, just to remind everybody that this meeting is being live streamed and also recorded, so we have everybody understand that. So I think we will not do introductions at kind of the way we didn't do it last time. I think that's not necessary in this format. We do have some guests tonight that will be introduced at the point that they do their presentation, so we can welcome them then. I think in the last short period of time, we got copies of some minutes from Karen. Have folks had a chance to take a look at those? They were from February, March, and there was a draft from May. So I'm not sure if folks would have had enough time to review those. Is it best that we put that off for another month so we can all look at that? Does that sound okay? Any objection to that?
No.
All right. Okay. We can do that then. So we'll do that in July at our July meeting. Any privilege of the floor?
I had one question from a previous meeting. I don't know if this is the right time, but I just wondered about the genetic testing question that was asked of the new CARS director. If we ever got an answer to that. And that can be answered anytime. It's just something that as I was reading the minutes, it crossed my mind that we had a concern about genetic testing of clients of CARS.
I don't have the answer to that, but I can certainly check in with Jessica.
I think it would be important to stress with her that we're concerned, not just that we're interested in, I mean, of course we're interested in finding out more, but I think a number of us specifically, and myself, I'm particularly opposed to this unless it's perfectly clear that the information is fully protected, because it's genetic information. It's not nothing. It's not. I want to know what CARS is doing to guard against disclosure, especially given problems that have historically been occurring at CARS. So I don't just want an explanation of what's happening. I want an explanation of the security procedures for that information.
Could somebody back up on that? My poor older brain has somehow lost this. And so what are they doing genetic testing for?
Frank, do you have information on that? Or
I think they said for medication.
I know vaguely. I'm not an expert on it. They use the genetic testing in order to help, as I understand it, design appropriate treatment. I think some of it has to do with medication, but I don't know the details.
Okay. And that seems like something you could pursue, get us a little more information. Thank you.
Sure, we can ask her to have information for the subcommittee.
Okay.
You mean for the substance abuse subcommittee or the?
Yeah.
I would like for the whole board to be assured of the confidentiality of the information and the procedures that they used check that information.
Can I also ask on the minutes that, are the subcommittees meeting?
Yes,
It's on the minutes of the board meeting from
Oh,
what,
okay.
February? Is it February? I think, maybe. Is that what you were asking? Maybe I'm answering the wrong question.
I think it might be in the March.
Sure.
meeting, but-
And I'm wondering about the minutes for the subcommittee meetings, if they're meeting.
Yes, they are meeting. We don't have the minutes yet, so we thought it would be useful to have the chairs present briefly tonight
Okay.
about what's been going on. So we'll get updated there.
Okay. Thank you.
Great. Okay, moving on to the commissioner update.
Sure. So good evening, everyone. We're going to hear some stuff throughout the agenda tonight, so I won't take a whole lot of time. I will kind of update on kind of COVID-19 stuff. We're in the reopening phase 2 actually now. I'm sure everybody's aware. And so we're navigating that, answering questions. We haven't had a lot of complaints. There's been some gathering issues that we're trying to address, but generally people are following the guidance, and so we're happy to see that. Our disease incidence is still low. We've had a handful of cases over the last week or so, but nothing too concerning. At least nothing that we can draw direct lines back to reopening on that would, draw concern. So that's still working well. Nobody in the hospital. You probably saw a couple of news articles in the last week or so with some folks that recovered and made their way out of the hospital, which was pretty awesome to see. Good news stories out of a lot of bad news stories. Oh, Karen, can you hear me? Can you send Sean Black the invite for this meeting? Link. Did you send it? Karen, did you send it? Okay, thanks. Sorry. So so things are going fairly well with COVID-19. The county is looking at its reconstitution of operations plans, which includes the mental health department. We did get some new guidance that an executive order extended the local municipalities 50% reduction in staffing for a bit longer. So the county is scrambling a bit to try to figure out what we need to do. We're at about 50% across the county, and I think we're below 50% at mental health because we've been successful with the telemedicine piece. So things are will continue the same way, at least for a bit longer. I can tell you the department, in preparation for moving through the phases and potentially bringing more folks back, we are working a plan to have more staff come to the building to do their work from there. They will still be doing telemedicine, but from their office. And much of that is to just get them comfortable with the new procedures and get them back into their spaces and see how the building is functioning, in this new order. And they'll be doing it, little bits at a time. So there won't be large numbers of people in the building at any time. We're attempting to do people flow restrictions in the building. So one-way hallways and the such, which is proving to be a bit more challenging than we originally thought, but we're giving it the effort. We've removed furniture and in our waiting areas and things in preparation for lower densities in those areas, if and when we do start bringing people back to the building from a client perspective. So lots of work still going on, but seems to be moving well. I do have a meeting tomorrow with the mental health and substance use providers. We've settled on every other week meetings now to check in on where things are and talk about, what we're seeing as far as demand and other issues. So that's happening tomorrow. I'd be remiss if I didn't mention the protests that are going on and the concern and anger I think a lot of people have related to the incidents in Minneapolis, and so we're understanding that we're likely going to have people that want to talk and might need help. So the team is kind of preparing themselves for potential clients that might.
Frank, I can't hear you.
You can't hear me? I'm sorry.
Okay, you just came back.
Is that better? Okay.
Yep.
Was I out for a while?
Yeah.
A second. Okay.
Guess question? I'm wondering, well, I'm making an assumption that the hiring freeze includes the positions in mental health, which is so many of the leadership positions. So I'm wondering what conversation may be having around that. I mean, I especially have to hand it to the staff, to have gotten everything going and keeping it going and things with, little administrative assistance. That's placing that burden on people that's not necessarily their job. So I'm just wondering where you think that might be going, or what conversations might be going on with the county or anything.
Yeah, so that's a really good question. The two positions, the clinic director and the deputy, were not included in the hiring freeze.
Oh, okay, good.
And so the county administrator saw the value in that, and he told us we could move forward. The challenge is recruitment continues, and our pool of candidates has not really increased. So that includes hiring a third-party recruitment firm to help find names. So we've extended that recruitment for another 30 days to see where that gets us. It also gets us a little bit further down the road as far as what things are looking like with COVID-19 and how we would go through a recruitment process and those kind of things. But they are not currently affected by the hiring freeze. That may change just because of the uncertainty of the financial situation. The county has significant concerns about our own revenues. The governor has already said that we can expect to see 20% reductions across the board if a federal stimulus isn't passed for municipalities. So we're talking about significant and severe cuts that we can be dealing with, particularly going into 2021. So everything I say today is all, contingent upon how things evolve in the next few weeks. So I think that's kind of generally the report. We're going to cover a lot of what I normally talk about throughout the agenda today. So I'll stop there and answer any questions if anyone has them.
Larry?
So Savante Myrick issued a statement about the gathering that took place on the Commons yesterday, encouraging people to be safe and to be, practice social distance and all of that. Have you reached out to, when you know that a demonstration may occur, have you been reaching out to people who are organizing them to encourage them to think about what they're doing and to be careful?
Well, to date, we haven't known in advance. We do know that there's one planned for Wednesday from campus down to IPD, and we have been in touch with Cornell to talk to the student groups that are planning that. But all of the others, we don't really know who's organizing them, and they've kind of been impromptu. So
Right.
hasn't been that chance, which why it was good that the mayor, who has a pretty wide audience, was able to get that message out for us.
Yeah, it was. I went to the Commons, and lots of people, I mean, we stayed way back from the central gathering, but some people were not as good at keeping social distance. So I think the more we can just get the general message out about that, because I think there are going to be protests here for the foreseeable future as things unfold with George Floyd murder.
Yeah, and quite honestly, Larry, there's some things that are more important. And I think this is one of them, right? I think we want people to be safe and we want, to get the message out as much as we can, but understandably, there's a reason why people are gathering.
Yeah, I agree.
Paula? I think you're muted.
I'm unmuted now.
Oh, okay.
I'm looking at Mutual Aid Tompkins, and it looks like they're saying that the next few Sundays from 2 to 5 p.m.,
Yes.
there'll be a meeting on the Commons. So
Yeah, I think there's definitely opportunity for us to
it
communicate.
might be worth talking to them.
Yeah, I'm not sure they're leading the process, but we can certainly.
They probably know who is.
Mhm.
I know some people who are, so, but there are ways to find out the information.
Okay. All right. Frank, did you have anything else or was, okay, thank you. Great. So we've set aside some time to hear from the chairs of the subcommittees. Elise, could you start us with what's been happening recently on your subcommittee?
Sure, and Sheila can feel free to help me remember. I don't think we have minutes yet, so I am doing my best to recall. But basically the last meeting we mostly focused on getting agency updates.
You're welcome, Kim.
Because we wanted to get a sense of where all the agencies that serve the DD population in the county are at in terms of their COVID response, but also if there are any service lines that they've had to shut down entirely as a result of the virus. It seems as though many services are forging ahead with complications. I know that statewide, in particular, residential agencies have incurred a lot of overtime costs and expenditures in relation to, COVID staffing levels. The one happy sort of side effect, I guess, reported by Racker Centers was that this seems to have given them a temporary reprieve from their staffing crisis. People are sort of staying put right now for whatever reason. Grateful to have a job. I know many people express concerns about being able to get PPE for direct care workers, which again is a concern statewide. And I did ask Challenge as the major employment support provider in the county if they had a sense of how many people with disabilities may have lost their jobs at this point. And they didn't have those numbers, but I'm hoping maybe in the next subcommittee meeting, we can begin to get a handle on the number of people receiving employment supports who may now be out of a job. Do you remember anything else, Sheila? I don't know if Sheila's on. Oh.
She is. She was getting off mute. You're off, Sheila.
Oh.
So, yeah. All right.
She's muted again.
Sheila, do you have anything to add? Thumbs up. I think she's freezing up too.
Okay.
You could also put in the chat box. Oh, go ahead. Yeah, you seem to be having some audio trouble, so maybe if you have any. So maybe if you have any additional input, you could put it in the chat box, because your audio, there's something up with your audio. We're not able to understand you. You're on a delay. Yeah, so that was the best of my recollection at this point. And if Sheila remembers anything else, she could just type it in the chat box for us.
Any questions for Elise? All right. Thank you. If we could hear from Larry next about the mental health subcommittee.
Sheila is saying they talked about the summer recreation programs and what's happening.
Yes. Thank you for the reminder, because that was a very important conversation. That we want to keep on our radar, the fact that there may be a reduced opportunity for youth with disabilities to attend summer programming. Although since that meeting, the summer camps are just falling like dominoes for everybody. So at that point in time, we were wondering, would there be summer camps, and then just making sure there was enough support for students with disabilities to attend, youth with disabilities. But at this point in time, I'm hard pressed to think of a summer camp that's actually going to happen this year, but it will still be an issue worth monitoring.
Okay. All right. Thank you. Larry, do you want to tell us about your meeting?
Yeah, so at the mental health subcommittee, Frank gave updates about how the department is functioning with COVID-19, talked about how the telemedicine seems to be very popular with most people, although I'm sure there are people who prefer face-to-face meetings, and that people who have been hard to keep connection with the department has experienced better connections with those clients. So I think one of the things that the board is going to want to look at, and the subcommittees are going to want to look at, is the opportunities that telemedicine presents, especially if it presents a particularly useful way to keep connected to people who have a hard time getting to the department, or have, just don't want to show up in the building for a whole variety of reasons. So that's one interesting thing. He also talked to us about the supervision structure, given that he's not able to be in the building. Although, Frank, have you been in the building more recently since the... Okay, so he has set up a pretty good supervision and connection between him and the people who are doing the work. Jeremy, what's Jeremy's title?
Fiscal administrator.
Is that he's the contact, right, between you and... Yeah, so I feel like there's a decent, solid connection, and Frank has been available to people. It's not as if he just hasn't been able to be in the building. As he talked about or mentioned, he is meeting regularly with our partners. I hate that word, with the other people who do mental health work in the community and substance abuse work in the community, and meeting regularly. I think there's been some issues about making sure that all the people who should be at the meeting are at the meeting, but I'm sure that's getting worked out, because there's a lot of people who should be around that table, given the size of the mental health system in our community. And lastly, I would just say, talk about the hospital and SP. Both the hospital and suicide prevention have experienced an increase in demand because people are reaching out when they're in trouble. What hasn't happened is a major increase in demand for other kinds of services like clinic services. So Frank is thinking, and I agree, and I think the subcommittee agrees, that we really need to do some work now and continue to do some work making sure that people know about our services and know about them before they get into crisis or reach out to crisis or more intense services before, when less intense services would be more appropriate, even for the situation that causes them to look towards the hospital or SP. So, and that's been an issue all along, but it's more of an issue because of the pandemic. I think that's it. Anyone who was at the meeting, is there any big chunk of info that I left out?
I think that covers it. Okay. Any questions for Larry? Okay. All right. Tom, can we hear about your subcommittee? I think.
He's
I think you're on.
I'm now unmuted. That's good. Anyway, me being new to this, I prepared some notes, which I'll read. The purpose of the Substance Use Committee is to focus on the needs of the addictions community and how we may address the needs of that community. The committee will need feedback from the county LGU as time passes, so there is an integrated effort. To accomplish this, we need to discover the gaps in the substance use field and how to address these gaps. The mission and function of the issues of concern to address these gaps. There are 9 of these issues, and I will run down through them. Number 1 is service access. At our recent meeting, we had addresses by Jessica from CARS and Angela from the Alcohol and Drug Council discussing the services they provide. Our next meeting will be addressed by REACH and by Dr. Joe Smith from TC3, who is the chair of the Chemical Dependency and Human Services Departments. Joe's thrust will be on how to entice more students to go into the addictions field and how TC3 can place more students in agencies as interns. The number of case acts in the field is diminishing, therefore the quality of services provided becomes more and more limited. Future committee meetings will be addressed by representatives of COTI, C-O-T-I, the hospital, peers, P-E-E-R-S, and mental health. Second issue is substance abuse treatment and prevention. We will address clinic staffing, student interest, agency reputation, agency ethics, agency presence in public schools, and the Ithaca College and Cornell University programs. This will also include the hospital. Third, we then move on to crisis intervention, where we will be addressed by a representative of the new detox facility, Open Access. We'll also hear from CARS about their new OPT clinic, and we'll have a speaker from REACH about NAT. And Southern Tier AIDS Prevention Program will also speak. Sometime along the line, we will also address the availability of SBIRT. Fourth is community engagement. Will include discussions of prevention, education, community resources availability, DSS, and the police. Number 5, under housing, we will discuss availability, affordability, both urban and rural, homelessness, and the rescue mission. 6th, with respect to transportation, we have observed that there are several rural areas that are poorly served and that the costs can be prohibitive. We'll be talking to TCAT, Getabout, and Uber. Number 7, vocational services. We will be discussing post-incarceration reentry programs, jail education programs, training for reentry people, trade union training programs availability, BOCES, the jail, and the Cornell education program at Auburn Prison. 8, under workforce, we will discuss the various sources of work and training, unions, and DSS. And 9th and last, we'll be concerned with recovery supports. We will seek to have presentations by AA, NA, LNN, ACA, SOS, judges from the various drug courts, attorneys, and the police. This is an agenda that should take us about 3 years to accomplish. A comprehensive project is to create a complete, detailed, informative, reader-friendly directory of agencies and the services they provide. This would include information for the agencies surrounding Tompkins County and somewhat nearby and just beyond. And that should keep us busy. Thank you.
Wow, that's very thorough. Thank you. Was there any specific discussion about any changes that the clinic directors have been seeing related to COVID? I was curious if what they were noticing as far as change in their practice or demand for services.
I don't recall them mentioning that, to tell you the truth.
I did hear the director talk about an increase of services, that they are getting more clientele and more intensity in the present group of people that they're seeing. Kind of anecdotally, more relapses.
Oh, the relapse rate is up, yes.
Yeah.
People are confined, they're home with nothing to do. And you give an alcoholic nothing to do and he's in trouble.
Yeah. And it took a while for the community to transfer from AA meetings in person to using Zoom and having a new website basically put up for the county. The state was divided up into a number of regions where AA meetings would take place. I think ours is area 47. So there was a good 6-8 week gap of just not having a lot of places to go that were viable. But I think that's significantly changed over the last month, where the word is out and communication is pretty good, that you want to go to a meeting, here's a site, and it's actually more variety now. The numbers have significantly increased in those Zoom meetings.
Yeah, the incidence of relapse is going to be pretty high because people are alone and they have nothing to do in a lot of cases, and they can sneak a drink because they are alone. So it's they're not in a good space.
Yeah. Thank you. Yeah,
Mary, just before we move off that, it shouldn't be lost that Jessica and Angela gave a joint presentation on the continuum of substance use services in Tompkins County.
Yeah.
In and of itself is a victory, right? I think for those of you that have been following those two organizations, it is refreshing to see the two executive directors working together and really focused on making sure that everyone that needs service in Tompkins County can get it here. So that was pretty exciting to see.
Yes.
It was nice to see your joint presentation. It's very nice.
Right. Yeah, there was from history, you know, that they've had some quote unquote turf wars.
Yes.
I think they both acknowledge it and have what they considered some a little bit more expertise in one area than the other. And, you know, it didn't seem like the egos were at stake at the last meeting, which, you know, has been somewhat of an issue over the years.
Well, as they spoke, it was evident that they were aware of as I spoke before, of the gaps, and they're trying to cover these gaps. And it's an acknowledgement of and the effort to meet, adjust to the gaps, and we're going to try to help them all we can. So we have a very comprehensive service.
Yeah, but I'm glad you pointed that out, Frank. That was certainly significant.
Yeah, and that'll really make our system much stronger. That's wonderful.
Yep.
Good. All right, thank you, Tom. That sounds like a great plan you have there. All right, so we're moving on to staff reports. Frank has invited two of the mental health staff to join us and talk a little bit about a couple of topics. So maybe I'll let him introduce them and we can go from there.
Sure. The first thing on the agenda is to talk about some quality numbers and information. And Jana Thibodeau, who's our quality assurance and improvement coordinator, who just joined us via video. I'll go through and give the presentation. There was a bit of miscommunication about who was going to be presenting the information, but Jana did all the work. So she should get all the credit for the slides and the data that's being presented. And then of course the team at the department gets the credit for actually doing the work that we're going to talk about. So pre-COVID, there was a lot of conversation, rightfully so, about metrics and what we were measuring. And we had promised that we would, provide that information to you. And I think it goes to show how ingrained this is in the organization that in the midst of COVID-19, we're still able to bring this to you and show you, what we're doing, because it is, just a part of who we are now. Just a little bit of background on, kind of our process. So what you're going to see is the high level data, essentially the data that I see and that the deputy sees related to how the department is functioning. And so these obviously aren't the end all be all or the totality of everything we measure, but these are the kind of ones that we pulled out and said, okay, if we look at these, from a commissioner level, it gives a snapshot of how the organization is performing on some of the key measures. So what ends up happening is that there's 4 Mondays in the month, most months. And so one of those Mondays is my meeting where I get to go and hear the different, the 3 programs, Health Homes, PROS, and the clinic report out on their data on this high level, but more importantly, talk about what they're doing to impact the data. Right, so I'm not necessarily looking at real-time data. It's often a month behind. But the important thing is that they're looking at it in real time, because what I want to see is I want to see the data. And if something's going in a direction, good or bad, I want them to be able to talk about what they did to have that happen, right? Particularly on things that need improvement. I want to know that they're working on those areas because they're looking at the data in much more granular levels. So please understand that what we're showing you here today is kind of the highest level of that. And so those 3 programs get a chance to meet once a week with Jana and the QAI team to kind of go over their data and talk about, what improvement planning they might be doing to impact the data. So they get into it very granularly at a monthly meeting as well. So for them, they're getting it as a singular group, and then they're also part of the larger group. So not only am I hearing about what's going on, they're also hearing from each other, and there's opportunity to learn and share, some of the things that they're doing to impact the numbers. So that's kind of the general process. What Jana put together a slideshow with some of the basic data that generally I'm looking at in the meeting that I attend. And I'm going to run through that and kind of talk you through where we are. I want to, one caveat, the intent with this isn't to tell you how things are going through COVID. It really is to just demonstrate what the data that we're collecting and kind of where things are. May isn't, while today is June 1st, May just ended. All of the notes and everything are not in place to give us a real good picture on how May looked yet. So I just want to kind of set that expectation up front, that the intent here isn't to, give you the detail about what's happened through COVID. It's really to kind of show you the data that we collect and how we use it. Certainly, as things come up in the slideshow, I will, if there's COVID impacts, we'll certainly talk about them as well. Just, I'm going to attempt to share this. So give me 1 second here. Magic of Zoom. Hold on, you guys. Can you guys see the title slide?
Yep.
Okay. So did you see it move to the next slide? All right, perfect. We're working. All right, so the key performance indicators that we're going to talk about today, progress note completion, treatment plan, caseload, so really services provided, types of service engagement, intakes, the days between appointment and census, substance use assessment, something that we were working on, and then high risk clients. So you can see these are high level indicators, but they really kind of give us the backbone of what we're trying to do as a clinic. And if there's something that's out of whack here, the program folks will have already been discussing it in a much more granular level in the data. So one of the first ones that we have here, hold on, I gotta move you guys again because I can't see. So this is outstanding progress notes. Those that have been around a while may have remembered that this used to be a problem, a pretty significant problem for us, not having progress notes done timely. And there's a lot of reasons why that's not good. The first is it's not good quality care because what if somebody's in crisis in between those visits and they don't know what happened at the last visit, and there's a lot of quality care reasons for it, and of course there's also the financial implications. We can't bill for notes that have not been completed and signed. And you'll notice at the bottom of this, the orange line, I guess it is the sum of pending. And so you can see it barely gets off of the 0 line. So that's been really good. This used to be a significant issue for us, and staff have really grabbed onto this and understood the values. So it's been a really significant improvement. You can see up at the top lines, it does tell you the total progress notes, that light blue line. So you're looking at, between 3,500 and 4,000 progress notes being done each month, right? So that's a lot of progress notes. Overdue treatment plans. So this is an interesting slide because if you look at that dotted blue line, it is trending up. But I would point out that the numbers that we're talking about are in the double digits. And I believe Jana told me it is less than 5% of our total. And so looking at treatment plans due, staff has done a significant job over the last few years of getting this number down. Obviously, if you look at where this chart starts, it's about the time that we lost our 2 leadership positions. So you can imagine you would see, a little bit of bump in the road, and that's kind of what this shows. But again, it's still significantly lower than it had been in years past. This, for folks that don't understand, we have to do a treatment plan every 90 days, and that there has to be a signed active treatment plan in place when a service is provided in order for us to bill for it. So there was a billing component to this. There's also the quality of care component as well, right? Having an active treatment plan means that it's been reviewed and updated and signed off on by a doctor. So it is important to have these in place. But again, a high level measure that's important for us to keep our eyes on. And like I said, as I see that dotted line going up, it's something that I know I need to talk to the clinic directors about what we're doing to So this is, I got to keep moving you guys around the screen. Sorry, in order to see the slides. The caseload services provided. So you'll see kind of how we've been progressing over the course of time here through 2019 and 20 over the last 12 months, fairly steady. And you can kind of see the totality of the work. We dipped in March, largely because of COVID-19. But as you can see, folks have got things back up in April as we've settled into the telemedicine world. So we did have a little bump, but the work of the team is really showing as they've re-engaged folks in a different way. So this is our caseload client engagement and show rate. And so these are the things that are that we're looking for related to people actually accessing the care, right? So our no-shows and those kind of things. So you can see the checked in folks has gone up from March to April, even beyond where we were in February. So that does show that we have been able to engage folks using the telemedicine. Because remember, from I guess the middle of March till today, we have not been seeing people in the office except for Medicaid management and crisis. So the fact that number has rebounded so quickly is a credit to the team and what they've been able to accomplish. The lines at the bottom are kind of the breakout of the different types of challenges that we see. And obviously the green line is what you would expect. It's canceled by provider, right? So in March, we canceled a lot of appointments. Because we were not fully able to see as many people as we had been. So if a blip like that had occurred outside of COVID-19, obviously that would draw attention, and we would try to figure out why it was happening. So that's kind of a good example of how we use this data. Is if there's a blip, we want to be able to explain that blip, and we want to know if it's something that's going to continue or not. And if it is going to continue, we want to be talking about what we're doing to reverse the trend. So that's really how we use this data in our decision making. So these are the types of service that we provide here in the clinic. And so you can see, obviously, the bulk of them are our clinic therapists, but you can see the other groups. And again, this just gives us a little bit more of a breakdown. So if we see something occurring on one of these lines that doesn't seem right, we ask the program director to explain that to us, and so we can understand why and if there's something we need to be doing differently. Probably a better way for me to do. Wait, what does this do? Oh, there we go. Now it's just Stu. I can see the whole slide. All right. So client intakes. This is a really good chart because it tells a couple of stories. right? Obviously, intakes are new clients coming into our system. And what you see here is a couple of things. So you can do intakes in multiple parts. And there was a time back in last year where we were trying to do the entirety of the intake in the first setting. We were using our open access team, and they were spending large amounts of time with the individual at the first session, and for a lot of reasons, we didn't like that. The clients didn't really like that because it just felt like it was, an hour and a half of paperwork with very little kind of therapy component to it. So we worked to kind of shift that. At the beginning of this year, actually right before COVID started, I was meeting with the open access team, and we tried to reconfigure. And so now the first intake is being done by the open access team, and they're generally spending 45 minutes to an hour. And then whatever they're able to complete during that time gets done. And then the person gets handed off to a therapist. Hopefully that therapist is a match. We do look to make sure that there's no conflicting issues on why that person shouldn't be assigned, and the open access team reviews that weekly. But then the therapist kind of completes the intake process. So the client is getting into a second appointment relatively quickly, meeting with a therapist that's likely to be their ongoing therapist, and starting to build that therapeutic relationship as they complete intake. So that's where you see the two lines converging together. But you should note that the total intakes is about the same. They've just kind of switched to being from 1 to 2 over time. But then it takes a nosedive there in March. And that is reflective of COVID, right? We talked about this last time we met, that the intakes they have dropped off. They have started to tick back up, and May's number isn't fully reflective of May because all the data isn't in yet. So that number isn't a true number. We're hoping that once everything is complete and in place, that will go up a bit, because we are seeing an uptick in intakes coming into the clinic. This is a real good chart where you can actually see where we made a change and it affected the data, right? So that's what we're using this for, is to be able to understand what we're doing and how it impacts the services that we're providing. This is our unique clients served by program. So you see the Health Homes Pros, the clinic, and then total active clients. This is unduplicated. So it gives a picture. And as the commissioner and the senior level folks in the department, these are things that we want to see. And if there are downticks, we want to understand what those are and how it's happening. We knew Honey, the important thing to point out is that over that time we shifted to more Health Home Plus. Most of our caseworkers are doing Health Home Plus, which means they can only serve up to 15 people. So that number going down is actually something we expected, because we are caring for the more acute cases. And so therefore we're only allowed to carry a smaller caseload. So our overall numbers have reduced. So we can explain why that number has gone the way that it has. The dip that you're seeing for the clinic and the clinic, really, because the blue one is overall, is, you're seeing a dip from COVID, right? That started to happen in March, right? We were on a fairly steady trend through February, and then March there was a pretty significant dip. So we'll be looking at that and hoping to see in April and May. April it might continue down, but then in May we would expect to see it start to tick back up. So again, a way for us to know kind of what's happening at a very high level in the SUD assessments. So this is something that we've been working on that, quite frankly, the data tells us we have a long way to go. It was my intention that we would be doing SUD assessments on everyone that came through the clinic. So that way we'd be able to understand if there were dual diagnosis or there were other services that we could connect them to, and or incorporate the SUD work into our therapy with them, with the client. And so you can see here the total number of clients by unit. And then the darker orange subset in that are the ones that have had SUD assessments completed. So as you can see, we've got quite a bit of work to do to fully implement, making sure this is getting done for everyone that comes through. Again, not all the data tells a happy story. And that's why we look at it, because it means, you know, we're tracking it so we can figure out how we can move the needle and impact these efforts. You're going to hear from Rich in a bit. Rich has been trying to make this happen for our clinic for a very long time. And, you know, it's quite frankly, much of it's due to his work that we're as far along as we are. But we've really got to integrate this further into our care. So an important measure, something we still have got a lot of work to do on. So this is active client hospitalizations. So as you can imagine, hospitalizations are a key number for us, and we're able to pull this information from the RIO, the Regional Health Information Organizations. Jana and her team have done an amazing job of getting us access in a meaningful way to that RIO data so that we can use it, you know, as part of our decision making. And so this is related to hospitalizations, a key measure for us. We don't want our folks going to the hospital. And so it's important for us to be continually managing these numbers. Obviously, April, there was a pretty significant drop off. And again, that was related to COVID. And I think just not accessing services. But again, a key measure for us that we need to be mindful of and watch. High risk list. I know many of you are familiar with some issues we've had with high risk in the past and not having a good process. We do now. Those are reviewed regularly. There's a report that's shared regularly. We know how many each group of providers has on the high risk list, both medium and high. There's a policy that identifies what qualifies you to be medium or high, and when you come off of those lists, when you go onto those lists. And you'll notice here on the right-hand column, it's by group. The different, the clinic looks at this at their meeting by clinician, right? So they get into the granular data to make sure there's an equal distribution if that's appropriate, and or if somebody is carrying more, a larger share, that we're supporting them appropriately and that they have what they need. So you can see that on the left-hand column, we have 10 in pros and 76 in the clinic. So we're acutely aware of those high-risk folks and following their care. Safety planning was a big issue related to high-risk folks. And so you can see that we look and we can tell by group how many folks are on our high risk list that don't have a safety plan. And if that exists, they are brought up at the high risk meeting. There's a conversation about why a safety plan doesn't exist. And the clinicians are instructed to get a safety plan in place the next time they meet with the client. So again, we'd love all of those to be zero, but those numbers are significantly lower than they were before. So made improvement, but still got a little bit further to go. And then also we want to know that our high risk clients have a next appointment, right? Because if they're high risk, they should have appointments. They shouldn't be out there waiting without an appointment. So again, we've got some folks here that need to get appointments scheduled for them. I think some of this has to do with COVID and our shift in March where we had less appointments available. So again, not perfect, but it's something that we monitor and we talk about these folks to make sure that these things get addressed on a regular basis. And then one thing I wanted to mention, there was Mary, who sits on our incident review committee, had asked for kind of a summary of what's going on there. And that is something where we have summary data, but I wasn't super comfortable sharing just raw data in a public meeting until we had a chance to kind of talk more thoroughly about the appropriateness of that. But we will be bringing you a more thorough kind of summary of the Incident Review Committee. But we did want you to know at kind of what they're looking at, right? And the categories of which we monitor and review cases. So natural cause deaths, suicide, accidental causes, overdoses, suicide attempts, and incidents resulting from medical issues. So those are the kind of things, the cases that are reviewed. We do have a spreadsheet with numbers for each one of those categories throughout the year. And the Incident Review Committee reviews each of those in more detail. And we'll be looking at this more to see if there's a way to kind of talk about trends related to these categories. Like I said, we need a bit more time on that. And so hopefully at a future meeting, we'll be able to provide that. That's the end of my slides. Jana, did you have anything that you wanted to share that I might have missed?
No, I'm happy to answer any questions that people might have.
So with that, Mary, we're happy to take questions.
Any questions from folks? I can't see people. So, oh, there you are. Okay. Any questions? Okay.
I think also moving forward, if there's information that's not included that people are interested in, that we can work on finding data for that.
That's great.
So I guess I would just ask, I know we had a lot of conversation about wanting this information brought. Is this what folks were imagining? Is it, I guess some feedback on, is this the kind of data that you would like to see on a more regular basis?
I think it was great. I mean, it gives that, high level view, which is where we should be looking at it. And with the trends and things, Larry may be able to think of something else he wants to know, but oh, you did mention, but I didn't see anything directly. Maybe Jana, those days, what the lag is from someone looking to make an appointment and being able to see a therapist.
Yeah, we can bring that data next time. We were looking at it this morning, and I think the data that I brought to Frank was from the dawn of 10/11, and it's probably not reflective of our more recent progress. So I don't know how often you do this, but we can include that for the next deck.
We talked before about doing it quarterly.
Okay.
Yeah, I think quarterly probably makes sense. And we can look at the way we present the data as to whether or not quarterly numbers make sense versus monthly numbers, those kind of things, but a quarterly kind of presentation. And my thought was we can share the data with you and as part of the packet and then field questions rather than, listening to me blather on slides for 20 minutes every quarter. Excuse me, certainly I can bring up any high points and if you guys after reviewing it have questions, we can kind of go that route. Versus a formal presentation every quarter. Unless you want a formal presentation, we can do that too.
I think also just a pitch for the key performance indicators that our team has spent a lot of time considering how can we look at just a few numbers which are truly representative of how the clinic is doing overall. Because if we look at 50 different things and examine all of this data, it gets very overwhelming very fast. And how to intentionally make decisions and focus efforts, I think, can be lost if you have too much data and also too little. So I think that we've tried to consider what are the big numbers that are representative, and if we work on improving those, it improves everything else in kind.
Yeah, and Janet,
I think you did good.
Yeah, they should get a lot of credit. Oh, there he is. They should get a lot of credit. In the beginning, we didn't know what we wanted to look at, right, from data. And I think at one point we had like 135 slides we were trying to go through our QAI meetings. Rich is shaking his head. He went through those, and they were just terrible. Not because they did amazing work and they were able to pull out this data, but we didn't know what we wanted or needed. So it took a lot of leadership from Jana and her team and the leadership in the clinic to really kind of pare things down to what's really important, right? What are those key measures that we want to look at from a department level? And then how do you look at that at a more granular level that will give the clinician and the senior clinicians information that they can use to change how we provide care in order to improve the service for our clients. And so Jana's team has done amazing work. Carolyn, who's Jana's data person, is like broken like 3 computers because they can't handle the data spreadsheets that she's working in and creating. So she's got like, I think she's got like IBM Watson in her office by now. In order to be able to process everything. Because you imagine we've got almost 2,000 people in our system. We're seeing them multiple times a month. They're going to the hospital. There's RIO information. All of that data has to be crunched. And they've done an amazing job of that for us, which has really put us in a position to be able to make changes and see how those changes impact our clients.
Hi there. I just wanted to thank you very much for providing the data. I think that was really helpful. What I've been hearing in the community too is that people that haven't typically struggled with mental health issues, with the murder that happened last week, with COVID, with all of the daily stressors, with kids doing distance learning, like just the combination of everything, it's almost like it's just building up and percolating. And I feel like many people that have never had mental health issues in the past are really being hit hard, and they don't necessarily have the coping skills to be able to deal with that. And so I have heard from people that they're reaching out to providers locally, private counselors, and of course, none of the private counselors have openings. And they are also reaching out to Family and Children's, and I have heard that Family and Children's is not getting back to them. And so I have referred them to the clinic. And, it is good to hear that the turnaround times are reasonable and that people are getting the help they need. I think many times people don't go to the clinic because it's considered a county clinic or a poor people's clinic or, whatever the case might be, an extreme clinic, for people that are really need extreme help. And, I think if we could change the conversation with people in our conversations in our community to let them know that, maybe it's just a situational, maybe it's just situational and, maybe just a few sessions with a therapist will help. And, this is something that I think our clinic can very easily handle. But I think, for all of us, it's important to really help with that stigma.
Really good points, Shauna. And we've done some messaging. I think even on the town hall, you were on with us. We talked about, folks coming in. We have seen, Larry or Stu, somebody alluded to the crisis line has seen a significant uptick in calls. So we know there's need out there. Our message is don't wait till it's a crisis. We're here for you now. And to be very clear, we are still taking people on a walk-in basis, not necessarily physically, but if they call and want to talk to somebody, we'll start an intake process with them that day. So that does still exist for folks, but you're right. There is a stigma with mental health care in general. And then I think, the public clinic, piece of it creates an even bigger challenge for us. But I hear you, and we are very much committed to trying to change that messaging. We're just not going to do it overnight, right? It took decades and decades to get us to this point. It's going to take a little time to kind of dig out of it.
Thanks,
It's
Sean.
Did you recognize me? I'm sorry, I don't want to speak up to
Go, Larry.
So that's, I think, the thing that Frank was talking about with the subcommittee, and myself as the chair and other members of the subcommittee have really for years talked about how to increase the public relations and the public image of the department. And I think that may be one of the benefits of the merger, which is we'll have more access to people who know how to do public relations because they exist at the health department in a way that they don't exist at the mental health department. So I think you'll be seeing some things happening as things reopen. But I also would just encourage people who are, you know, contacts for people like Shauna or me or other people who know people to just talk about the clinic as I mean, there are lots and lots of people who go to the clinic who people would be surprised go to the clinic. In the public mind, you know, a public mental health clinic sometimes gets a lot of bad publicity. So you need to work on that.
Okay, thank you. Frank, would you want to move on to the next piece? Or
Yes, and to all of your benefit, I'm not going to be talking anymore. I'm going to turn it over to Rich Shaw, who I think most of you all know. He's been with us for quite some time, and he's our dual diagnosis coordinator. And he also kind of runs SPO for us for the community. And I thought it might be a good time to get an update on that and hear how that's going. So Rich, I'll turn it over to you.
Okay, thank you. I'm competing with a few lawnmowers right outside my window, but hopefully you can hear me. What I thought I would do is just kind of go, I think a lot of people don't know what the single point of entry is. In every county has one. Sometimes they're referred to as single point of entry. Sometimes they're referred to as single point of access or SPOA. And there's not to be confused with ones that are for children and youth. They do a very different set of things than we do with the adult single point of entry or single point of access. And what the single point of entry does in our county for adults is basically two things. One is help people get special housing who qualify for it by meeting the criteria for serious mental illness. That's the official term. I didn't pick that term, but that's the term the state uses, serious mental illness. It used to be referred to as severe and persistent mental illness, which is a bit stigmatizing. And so the state has kind of phased the usage of that term out, although you will still hear it at times. That's been phased out. So people who meet the criteria for serious mental illness, and there are state criteria, it's included in the application that we give people who are looking for housing, where a clinician fills out the criteria form and basically attests to the fact that the person does meet that criteria. How I originally just sat in as a committee member, and that started out because part of my job is to look at how people with co-occurring mental illness and substance use disorders are treated within the community. As you probably all know, there's two different systems for mental health treatment and for substance use disorder treatment. And they overlap a bit, but they're still pretty separate. So when people came in to the SPOA committee or the SPO committee for housing, one of the things that's written in that criteria is are the issues that the person's having that where they meet the criteria, are they due to the mental illness or are they due to a substance use disorder? And if they're due to a substance use disorder, they don't qualify. So part of my job in sitting there and originally on that committee was to advocate for people and say, hey, not so, you know, people often do have a mental illness and a substance use disorder. And I was a bit of a watchdog in trying to make sure that people weren't screened out because they had long substance use histories. I'm happy to say that now we don't screen anybody out due to their substance use histories, and that's been a major change in how things have run with the single point of entry. And so basically what the single point of entry does, one, helps people get into special housing through the Office of Mental Health. And 2, it connects people to what's called assertive community treatment, the ACT team, which is really the highest level of outpatient treatment somebody could get in New York State. So what SPOAs and SPO committees do is they're really kind of gateways for people to get those housing benefits, so to speak, and also to be connected to the ACT team. So what we do is we meet with a committee twice a month. One of the things about single point of entry committees is that they are done differently from county to county. In fact, I learned recently Cortland County doesn't really have a way of doing things. There's no formal SPOA for adults. So I was asked to help them, to have them look at what we do, and actually had the SPOA coordinator from Cortland County sit in on our meetings remotely and look at what we do. But what we do is we sit as a committee twice a month, and some of the people who are on the committee, it's the leader of the ACT team, a representative from Unity House, a representative from Lakeview Health Services, a representative from our care management team. Typically the clinic director attends. She attends pretty much all of our meetings. Occasionally we have the PROS program director attend as well. And we have a few other people representing different parts of the Lakeview housing system. And what we do is my job is to look at all the applications. If somebody wants the special housing, which I'll go through the different kinds of housing, they have to fill out an application. It's a standard application. There's no one application that's universal throughout the state, which is unfortunate, but counties are very different in how they do single point of entry. So there has to be some differences, but I'd like to see a more universal application. The children's SPOA has a universal application that's used throughout the state. But the applications come to me. I see if they meet the basic criteria, if everything's in order for it to move ahead. I put it on the list for our committee to review. Thanks to IT, our county IT, they helped me to be able to put all this information on a secure location online. And what that allows us to do is that members of the committee can look at the applications and the lists of who's waiting for housing basically in real time. So as we're getting applications and I'm looking them over, I put them online so that committee members don't have to wait to the meeting to look them over. What happened in the old days is that people would come into the meeting. I would have made copies of all the applications. Some of them are 30, 40, 50 pages long. And sometimes we get 10 per meeting. And I'd make copies of all of those and pass them out, and people would be reading them for the first time in the single point of entry meeting. Now that doesn't happen. People read them before they get to the meeting. And when they get to the meeting, they're ready to talk about the people on the list and what's most appropriate for them as far as the next move. And so what most of the meeting time is taken up with looking at the new applicants and connecting them to the next step in trying to get housing. And the next step typically is having one of the housing providers, either Lakeview Health Services or Unity House, contact them and do a screening, show them the housing. There's a number of different things that they'll do with somebody. If somebody isn't sure what they want to do, there will sometimes be a joint screening, which means more than one program meets with the person and they both explain their programs and they see what the person is most interested in. But so the kinds of housing we have here in this county, and I'm going to use the newest terminology. There's still the old terminology rolling around, and I still use the old terminology a lot, but I'm going to use the new terminology. So what we have here in this county we have OMH licensed congregate treatment sites. Those used to be referred to as community residences. We have 2 of those. One is called Markham House and the other is called Elm Shade. Markham House houses 14 people and Elm Shade houses 9. So somebody who, for example, is coming out of a hospital and needs that level of housing where it's basically group living, there's cooking on site, people pitch in and live communally within each of those houses. and kind of share living areas, which is different than most of the other housing. It's a level of care with the highest amount of supervision. So a typical referral would be somebody coming out of Greater Binghamton Health Center. They want them to step down into a community residence where there's going to be a lot of supervision. The purpose of the community residence is to help somebody reach their highest level of independence. So not to stay in the community residence, but to become more and more independent. And I'll talk about some of the more independent kinds of living. But to give you an idea of the housing right now, there's one opening in Markham House. There's 2 openings in Elmshade. And much to my surprise, I'm reading the actual list that we're going to be going over tomorrow in the SOA, is there's only 1 person on the list. That's the first time in the probably 11 years I've done this where I've only seen 1 person on the list. So that's good news, I hope. Sometimes people are on the list for a long time and they find other options, or they're no longer at a number that we can contact them. So sometimes people come off the list, not because they're housed, but because they've been lost to contact, unfortunately. But in this case, I think that most everybody who's been on the list has found some type of housing, and we're down to just 1 person, which is really good to see. I will mention too that with COVID, that didn't change anything as far as SPOA goes in terms of meeting as a committee. We didn't miss any meetings. We kept meeting remotely, which is what we're still doing. So those are the 2 community residences, otherwise known as licensed congregate treatment sites. Another part of housing that we have here is what's referred to as apartment treatment programs. And those are apartments leased by Lakeview Health Services that somebody can live in, but there's a fairly high level of supervision. The person comes in with a plan of what they need to work on to become more independent. So for example, somebody may need help with budgeting or learning how to cook their own food, or how to maintain their own apartment and live independently. There are 32 of those sites available in theory. The problem with that is that Lakeview has to lease them. They lease them, Lakeview themselves leases them. They aren't leased by the individuals in the apartments. And recently they have lost some of the leases. And so there are people who need to move to other leased programs within Lakeview Health Services. So one of the things that happens is those apartments come and go. We can have 32 in our county, but that doesn't mean that Lakeview Health Services has 32 places leased. Some people, some of these are roommate situations. So there's more than 1 person sharing in an apartment. And that can be very good where people are supporting one another, or it can be detrimental to somebody's well-being in that there may be somebody in the apartment who is using substances or inviting people in who create issues within the apartments. And I can go on and on about some of the history of the problems that have occurred in some of those apartments. That list is down to 10, which isn't too bad. That list can get up into the 20s. And so I mentioned these lists, there's always people waiting to get into housing, and some of the lists can get pretty long, which I'll talk about more. So right now there's a 32 capacity, but there's 6 apartments that they need to lease where they have lost the leases, and they need to get new leases, new apartments for people who are already in their program to go to those apartments. Another level of housing is what's called community residence, the single room occupancy. And that's a building, relatively new building, a little over 10 years old, I think, that's across from the DMV on 3rd Street. And that has 38 efficiency apartments. People are served meals and given medication on site. And that, unlike the other housing programs I've mentioned, there's not a rehabilitative aspect to that. If somebody comes and lives there, they can stay there indefinitely. They don't have to move out. People do occasionally move out. They decide that they don't want to live in an apartment building like that and want to live independently in their own apartments. So people will do that. We will sometimes have what's called internal transfer. Sometimes they transfer within Lakeview's housing from the single room occupancy building to an independent apartment. That level of housing, because people do not need to move out, they can live there indefinitely, the list can grow very, very long. It has shortened recently, but it's been a pretty big list. And right now there's 14, which is the lowest number I've seen probably in 10 years. So that's good that it's lower than usual, but it still means that people are waiting indefinitely to get into an apartment. There have been some recent openings, as many as the current number I have here is 6. So some people have moved on, which has led to some openings, but there's plenty of people waiting to move in. That list there's subcategories of that list. Priority. So somebody on an assisted outpatient treatment order, somebody who's been court ordered to have treatment in this county may take top priority. Somebody coming out of a state hospital can take top priority. So there's a priority list. There's an internal list where somebody's moving from another part of Lakeview's programs and wants to move to the SRO. And then there's the general, what's called the community list. That list has been up into the 30s and higher at times with no movement for weeks or months. So there is movement now, and the list is getting smaller. Again, I just have to say that sometimes the lists shrink, not necessarily because everybody's being housed, but because people are being, have been on the list for a period of time where they're no longer able to be contacted. They change phones or they move. And if Lakeview, after a certain period of time, cannot contact the person, and we have to make a decision at some point to have the person taken off the list. I tend to keep people on the list until they're housed. So unlike a lot of other spokes, I find where people are taken off the list much more quickly, I tend to keep people on until I know there's some definitive answer as to what has happened, what is the outcome. The next level of housing is what's called supportive scattered site housing. Used to be known as supported housing, and these are apartments out in the community. The people who qualify for them lease in their own name, and it's basically just one step removed from being completely independent. There's very little supervision. Person is helped to move in, to get rolling, checked on once or twice a month, and the goal of that program is for the person to eventually get Section 8 and to live completely independently. And I'll just end with, those are the housing, that's the housing that's available. And then, like I say, the other issue that we work on is helping people get connected to ACT. So that's a really vital service that the single point of access does here in the county, is to help people in the community who qualify for ACT services to get ACT services. And in addition to meeting the criteria for serious mental illness, somebody has to meet there has to be additional criteria met to say that this person, the level of treatment for this person should be ACT. So part of ACT referrals going through the single point of entry is so that we're making sure that, you know, those are really coveted slots. ACT has a total total capacity of 48, but they cover multiple counties. We are just one of several counties that they cover. And so we have to make sure the people in those slots are the ones who need it the most. But I'll end with that and see if you have any questions about.
Okay, yes, we can take a couple of minutes for a few questions. Larry?
Well, it's not really a question, it's a point. I believe that this is still true, that Tompkins County has the most people on the ACT caseload for the region. Is that still correct? Yes.
Yeah, we're the main resource for most of they're called the Finger Lakes ACT team. We comprise most of their caseloads.
And in fact, the administrative and programming office moved from Watkins Glen or Geneva, I can't remember, to Ithaca because of that reality, and because the subcommittee continues to hope that EPC, Elmira Psychiatric Center, and the state will allow us to have more slots and to cover the entire county, because long-term members of the board know that there are still some small pieces of the county that are not covered by the ACT region.
Right, and that's unfortunate that we, somebody, depending on where they live in the county, may not be, they may be outside of the catchment area of the ACT team.
Right. So we still have some work to do.
Sure.
Any other questions for Rich? Thanks, Rich. That was a great presentation. Good.
Thank
very
you.
Informative. Good.
Thank you.
All right. Well, I think we've come to the end of our agenda. Any other thoughts, comments? All right. Well, Travis?
I just wanted to make people aware, if they weren't already, probably most people know, Cornell's Counseling and Psychological Services has hired a new director. She will start on July 1st. Her name is Dr. Alicia Sunsmo, and she comes from the University of Wisconsin. Yeah, we look forward to welcoming her in our community. So
that's great. Thank you. Larry, do you have your hand up, or is that?
No, I was just scratching my head.
Okay, thanks. All right, can I have a motion to adjourn? Larry, second, Travis. Okay, all in favor?
Aye.
Aye.
Great. Thank you all for coming tonight. We'll see you next month.
Thanks, everyone.
Thanks, everybody.
Good night.
Yeah.
Thank you. Good night.